MSN, you are there, you can help me.
Yeah, sure, doctor.
Yeah. So, as a co-host, you can admit.
Okay, sure, doctor.
Yeah, great. Great. So that's working fine. Okay. Good afternoon, everyone. You can hear me, I think.
Yes, doctor.
Yeah. So this is a compilation of all the topics, which have come up from students regarding the subjects they would like revised. So I was already preparing some notes for you guys, and I've added on all these most importantly because your felt need is that in malignancies there is a lot of gaps between knowledge and what is taught and what is appreciated as good answers. Now, first and foremost, please, in medicine, there is nothing cut and dried that this is going to remain so forever. So, we need to continue to learn and improve our knowledge as we go along. So, possibly what you learnt in year one may not be so accurate now in year five. So, that we should always be ready for and always evolve as we go along and read new things and learn new things. Okay, so with that background in mind, and I've shared a lot of this data with you, feel free at any time that if anything appears at a discrepancy with what you are learning from your pakas in the hospital or what you are reading from journals or your textbooks, don't hesitate to get back to me because it's only when we exchange ideas and sources of information that we are able to finally distill that what is really correct and what is not correct. An article of mine is going to come out soon through Veritas, which is regarding, a lot of false information is also spread through the internet, and we should not become victims to that, and especially in health related matters. So, with that background, let's start quickly and go through all. So, first and foremost, the pattern which we should have when we are answering any SAQ questions. So, this is just one example on thyroid gland. So, usually a picture is given, and it is obvious from the image that it's a multinodular goiter. You are seeing distended veins, so you can anticipate that possibly there is a retrosternal extension which is causing then some superior vena cava obstruction. So this kind of a patient may be there even in your clinical examination. So that is why this SAQ becomes important, and in case an X-ray is shown, you can see that the trachea is shifted to the side and that you have to answer the following list questions. So these are very simple actually. List two findings which will confirm that the swelling is a thyroid swelling, and we know that a swelling in the front of the neck which moves up with deglutition and does not move with protrusion of the tongue is likely to be a thyroid swelling. Then in Pemberton's test, we know that once we ask the person to raise their right arms and approach both the ears, there is a congestion of the superior vena cava. So it will be evident with these veins which are seen on the neck, they will become more prominent, face will get congested, patient may have breathing difficulty, there may be stridor. So these are all the findings we get in Pemberton's test to reconfirm that there is a retrosternal extension. Then, in case of thyrotoxicosis is detected, outline the extent of surgery advised and the preoperative preparation that is advised. Now, for this, we follow the American Thyroid Association guidelines in which they recommend a near total or a total thyroidectomy. So, for benign, malignant, for all, I mean, it will be very, very rare situations where other kinds of thyroidectomies are acceptable, but most of the time, if you pick near total or total thyroidectomy, you are going to be right. Then pre-operative preparation. So for thyrotoxicosis, the pre-operative preparation given well in Bailey. So please go through that and make out the answers in your own words. There is no point me spoon feeding you and you trying to remember all that. Yeah, it's much better that you write it in your own words from Bailey, and thereafter you will have 8, 10 lines which you can write. And that is another thing. Please don't answer SAQs with just couple of words, that you pick the keywords, because when we make slides we choose the keywords, and like you are seeing that there are so few words actually here, and I'm talking for so long. So there is so much which needs to be written. So every time, please write in complete sentences to explain what you are trying to achieve. That antithyroid drugs are given to achieve a euthyroid status, instead of just writing antithyroid drugs. So that is the way to really answer your SAQs and get more marks. So when there is a 2 3 paragraphs written, we are more likely to go towards 4 4.5 and give you nearly maximal marks, rather than you just putting 4 or 5 keywords down. So that is my sincere advice to you. Learn to write in complete sentences and explain what those keywords mean. Then complications of surgery are also given well in Bailey. Just pick out the titles, and then you know how to explain hemorrhage, infection, thyrotoxic storm, hypoparathyroidism, recurrent laryngeal nerve injury, and hypothyroidism, because this patient will go for near total or total thyroidectomy. So like that, you have 5 6 complications which you can write. Then coming to the next common situation which crops up is regarding breast. So a lady with breast, she may present with a lump, she may present with a discharge from the nipple. So whatever is the presentation, we know that in case diagnosis is asked, we will always go through the triple test: the history and clinical examination, imaging, and a core cut needle biopsy. Don't go for FNAC, because then explaining all that takes some time, and we know from the clinical practice guidelines that the preferred method of achieving diagnosis is a core cut needle biopsy. Then this question also is quite commonly asked regarding what makes a lump a T4. So that we have learned the exact thing you can pick up from the AJCC cancer staging manual, but it's given in most books correctly. So you can follow from the slides what makes the tumor a T4 tumor. Then the molecular subtypes of breast cancer. So they are given in the clinical practice guidelines, and we know the luminal A, luminal B, HER2 enriched and triple negative, out of which luminal A is the best and triple negative the worst. So whichever way this question is asked, you can answer that. Then the lymph node characteristics, including in the N2 characteristic. So this N2 category is when the nodes are matted together, and when the apical nodes or supraclavicular nodes are involved, or axillary or internal mammary nodes are involved, that becomes N3. So be careful what is asked, whether N1 is asked when they are mobile and discrete, and N2 when they are matted together or fixed and they belong to level 1 and level 2. Then outline the management of this patient. So when this patient has got a T4 N2 lesion, it becomes a locally advanced breast cancer. So all this we will go through when we are discussing breast, and in the clinical practice guidelines, good algorithms are given. So we will repeat this, so I won't go over it now. Then acute cholecystitis. Now, acute cholecystitis, the Tokyo guidelines are given well, and I find students are not paying attention to it. So be sure it will crop up in some form or the other, either in your Viva or in the theory questions, in the CA or in the final exam. We need to be very clear about these Tokyo guidelines, which are used to make a diagnosis, make a definite diagnosis of acute cholecystitis. All three criteria should be present, that one local, one systemic, and one radiological criteria should be present for us to make a diagnosis. Small table in Bailey does not take much effort. It just indicates which students have read Bailey and which students have not. So please try and indicate that you are one of those students who stays updated with the current textbooks rather than picking up knowledge from various internet sites. Then complications caused by gallstones are also very clearly given in Bailey, that all the from starting from biliary colic, you can have acute cholecystitis, you can have empyema, you can have necrosis of the gallbladder, you can have perforation, peritonitis, sepsis. So all those can be caused, and occasionally when the gallbladder perforates through its wall and enters the duodenum or jejunum, it can eventually even lead to ileus. So though we call it gallstone ileus, but actually it's a mechanical obstruction due to the gallstone acting as a bolus which is obstructing the lumen. Then severity grading. This also is given well in and the Tokyo guidelines reproduced in Bailey and Love. So though the categories are very many, but if you understand what is behind it, it is quite simple. That in case there is organ failure, it goes into category 3. In case the patient comes late, there is a mass, there is extra inflammation which is apparent on the ultrasound examination, leukocytosis is there. So all those features will point to a moderately severe acute cholecystitis, and mild acute cholecystitis or category 1 cholecystitis would be when there is none of these features are applicable. So those are the cases which can immediately go for surgery. Then outline the management of this case, acute cholecystitis, the management plan also. So diagnosis, assessment of the severity and management, all three are given well in Bailey. And they are all from the Tokyo guidelines. Please make that effort to note it down and remember it. Then carcinoma stomach. This question was asked earlier along with some anatomical drawing that you had to make of the arterial supply and lymphatic drainage. So here of course it is straightforward. The symptoms presents with dull pain in the epigastric region, anorexia, nausea, early satiety. Always whenever you hear this, either as a question or you see it written as an SAQ or an MCQ, it points to the stomach getting full early. So that means it is unable to distend, which is usually one of the infiltrative types of gastric malignancy. So intestinal and diffuse, so it is the diffuse variety which involves the entire wall and the stomach cannot distend. Then weight loss, vomiting noted over the last 3 months, black tarry stools, left supraclavicular lymph node is palpable, system Mary-Joseph's nodule is visible, and there is a mass in the epigastric region. So all of this is going to point towards the malignancy in the stomach. Supraclavicular lymph nodes points to GIT malignancy, system Mary-Joseph's nodule points to intraperitoneal malignancy which is advancing through the falciform ligament or the median umbilical ligament, and patient is a smoker, regular alcohol use, so all those features point towards the carcinoma of the stomach. Then other diseases which are to be considered, peptic ulcer will be considered, then gallbladder disease will be considered, also cirrhosis, portal hypertension. So all these conditions, you have to know what is present in the epigastric region. So, a person who regular alcohol use can develop cirrhosis, can develop hepatocellular carcinoma, which will present as a mass in the epigastric region. Then carcinoma colon, also the omentum is there when the transverse colon is there. If a malignancy is in that region, there will be a mass in the epigastric region. So from colon, stomach, liver, gallbladder, so all these can cause, and of course chronic pancreatic diseases, if there is a pseudocyst of the pancreas, that also will present in the same region. So this anatomical idea you must have always, so that you are able to write a correct differential diagnosis, which is what this is actually testing. When we ask differential diagnosis, we want to see whether you have an understanding of what is the anatomy. Then the information about the disease gained from the presence of Sister Mary Joseph's nodule. So when Sister Mary Joseph's nodule is present, that means disease has crept up through the falciform ligament or through the median umbilical ligament and has come to lie in just behind the umbilicus and is now growing there. So all that indicates an advanced stage of malignancy. So commonly we see it in carcinoma stomach, may also be seen in carcinoma colon, pancreas, ovary. So all of them can eventually, the disease can creep up and it shows an advanced or peritoneal spread of the malignancy. Then outline the management of this patient. So carcinoma stomach, how will it be managed? So in every GIT malignancy, whatever be the stage, we always try and resect it because of the two dangers, that is of the danger for perforation and hemorrhage. So if possible it is resectable, we will resect it. Otherwise the standard treatment is palliative chemotherapy. If patient cannot eat, then we can, if there is gastric outlet obstruction due to the disease, we can put in a stent, or we can insert a feeding jejunostomy to continue to ensure that the patient has nutrition and builds up his weight while we are considering other forms of treatment with chemotherapy and radiotherapy. Then upper GI bleeding. A 65-year-old man with a history of regular alcohol use and 30 pack years of smoking had an episode of vomiting after a night of excessive alcohol consumption. It contained fresh blood. So upper GI bleeding, four diseases to be considered. So from peptic ulcer, duodenal ulcer, carcinoma, stomach, esophageal varices. So all these will become in the differential diagnosis. Then list two investigations with the relevant findings that will help in the management. Of course, there are other inflammatory conditions like esophagitis, gastritis, so all of them can be included here, which will cause Mallory-Weiss syndrome, which will all cause some amount of bleeding. Then list two investigations with the relevant findings. So among the investigations, we know when we are routinely asked multiple investigations, then of course we will say that we want to assess the general condition of the patient and exclude comorbidities, and then do investigations to establish the diagnosis. But when you have to pick only two investigations which are going to help you in the management, then in this case one will be an upper GI endoscopy and the other will be an ultrasound examination of the abdomen, which will help you eliminate esophageal varices, portal hypertension, cirrhosis liver, or a malignant mass adjacent to the stomach. Then this ABG report, this I've been seeing, it's been asked several times in different forms, and most of you are correct. So there is nothing much to discuss here. You know the pH, whether it's on the acidotic or alkalotic side, and then we see whether the changes in the respiratory or the biochemical, the metabolic parameter, with this, what if the change is happening towards the acidotic side, then that is the culprit. So here the PaCO2 has changed toward the acidotic side and patient is acidotic, so it's respiratory acidosis. If the bicarbonate had dropped and PaCO2 had remained normal, then that would have indicated a metabolic acidosis. So that's quite simple, and most of you are doing it correctly, so I won't take much time here. Then outline the treatment of this patient if the bleeding is from a benign lesion. So you can choose anyone. So most of the time we will choose peptic ulcer disease, and bleeding from a peptic ulcer disease, you can write much more regarding the forest classification, and you can write about the methods We can use clipping, we can use injection of adrenaline, we can use glues. So all those methods to stop the bleeding. And then we will check for H. pylori infection and do H. pylori eradication in kids. It is a peptic ulcer disease. You want to talk in more detail about esophageal varices, you can do that also. You want to talk about malignancy, you can do that. So whichever one you know best, you can apply. So there is a lot of scope here, but do read the question whether it is giving you the option or it wants specifically what you have to address. Then perforation, peptic ulcer, that also is quite a common question, and students keep making mistakes. They miss out on the common clues because in all this scenario, patient will be acutely ill. So all these other features are going to be common. Patient is going to run a temperature, have tachycardia, have tachypnea, have low BP. So all these features are common in many of the acute illnesses. Now, what you have to see additionally is what has happened to the abdomen. It is held rigid. So, whenever you see the term rigid, rigidity, it points to peritonitis. And peritonitis, commonest cause is GIT perforation. So, that becomes your first clue whenever you see rigid or rigidity. Then you look for other things which are mentioned here. So here DRE reveals bogginess that may be there, and WBC count is elevated. Serum amylase is not more than 3 times the upper limit of normal. So that is one clue that it cannot be pancreatitis. If it was acute pancreatitis, we would get a serum amylase more than 3 times the upper limit of normal. So 140 into 3, 420. So it has to be 430, 440, 500 for us to think of acute pancreatitis. Then look for other signs also. Sometimes there may be absent liver dullness, which again points to pneumoperitoneum, or the abdomen is not moving with respiration. So that will also point towards peritonitis. So these are the other signs which we can pick up. Then for diagnosis to be so, if all acute conditions of the epigastric region can come as the differential diagnosis. ABG report you all are very good at. Then outline the management. So in perforated peptic ulcer, the standard is once the diagnosis is established with history taking examination, then X-ray of the chest erect view or an abdomen erect view will show you gas under the diaphragm. Then after that, once the diagnosis is confirmed, the peptic ulcer disease which has perforated is treated with exploratory laparotomy. Then first step after exploratory laparotomy is a peritoneal washout. So all the muck which has leaked out from the perforation, that is washed out, and then the perforation is closed. So if it's a small duodenal perforation, can be closed primarily and supported with an omental patch. And in case it is a gastric ulcer, then we always take a biopsy because underlying malignancy is always a possibility. And if the ulcer is very big, then we may do a gastrectomy. So that part of the diseased stomach is removed, and that becomes the treatment for this perforation. So peritoneal toilet is an important step in this management. Then coming to acute pancreatitis. Etiological factors for acute pancreatitis, we know that it is normally gallstone disease. So there is choledocholithiasis and of course alcohol consumption. Then you have all the others which you can trauma, endoscopic pancreatography. So all those are the secondary causes which you can list out. So elevated serum calcium, hyperparathyroidism. So all those can also cause, and of course congenital conditions like pancreas divisum can also cause acute pancreatitis. Then two systemic and two local. So this again is quite easy. So systemic complications, we know that whole lot given well in Bailey. So from hypotension to ARDS to acute kidney injury, liver failure. So all organ failures can happen as part of systemic. And of course there is hypotension and DIC. Then local complications. So locally there can be acute peripancreatic fluid collection, acute necrotic collection, and of course, if this does not get absorbed in 4 weeks' time, then subsequently it develops a wall around it, and then it become a walled off necrosis or a pseudocyst of the pancreas. Then list the features assessed and scored on admission to predict the severity of a case as per Ranson scoring system. So the features, we have a mnemonic which we use on admission, that is GLO. So glucose, age, and LDH, AST, and WBC count. So once you know the mnemonic, then you know you don't have to waste your time thinking of other things. So you just write the characteristics which are included and their level. So either you can write glucose in milligram per deciliter or millimoles, depending on whichever you're comfortable with. Then outline the early management of severe case of acute pancreatitis. So this also small table in Bailey. Please go through it. Many times this question has been asked and all those answers have come to you. So please do look at it. Now, I know I'm going a bit fast, but if there is any question, don't hesitate to ask on the chat, or you can send it to me on WhatsApp and I will answer that. Now, this also, many students had doubts on how their cases are going to be assessed. So, this is the pattern which we are also using for your EOP. So, how well you are doing the physical examination. So, that is why I keep sending you that clinical examination PPT, so that you revise how to do the liver examination correctly, the spleen examination correctly, so that there is no confusion. Then how you, whenever there is hepatomegaly, what you will understand from it and what else. It's not just that you have palpated an enlarged liver, but you have to talk about the edge of the liver, tenderness, the surface, the consistency. So all those things also have to be mentioned whenever you encounter an enlarged organ. Then all this, how you analyze all this information which you pick up on clinical examination, and how you are able to present it. So most of the time, we become book bound, that we just write it down on our iPads and try and repeat it, or write it on a piece of paper and keep reading from it. Remember, this is a viva, you are interacting with the examiner, so you must be able to remember most of it in your mind and look the examiner in the eye when you are talking. So don't be all the time reading. So please practice that. So this tendency I have found lately, that more and more of you have veered. The earlier batches have done well in remembering the presentation findings, and at least aiming to present without referring to their notes. But lately this has sort of deteriorated. So in this period, try and work out how you can remember most of the examination findings and present with minimal reference. I don't say make a drastic change and totally disregard the paper, because if you get stuck and don't remember anything at all, then that will be very embarrassing. So do keep that paper with you so that you can refer it to it if needed, but try and say a couple of sentences at least without reading everything from the paper. So language, and that is why it is important to keep asking questions during class and answering, so that this exercise of how we formulate sentences as answers, because that single word answer is not going to get you through your viva. So you should be able to explain what you are saying, that there is tenderness there, there is guarding here, and why is that guarding there. So all that you should be able to explain in sentences rather than just single words. And of course, knowledge. So most of you have acquired adequate. So I don't think there is going to be a problem there. But it is just this showcasing that you have the knowledge, but how do you present it in a beautiful manner and score more marks? So that is the trick of the trade. Then a plan of a management. So in every situation, we know what is the correct treatment for a perforated peptic ulcer, bleeding peptic ulcer. we know what is the plan for acute cholecystitis, and if there is choledocholithiasis, what should be the plan. But then we should be able to narrate it out sequentially, not that the last thing comes first. That first we will go through that entire steps, that history examination, so all that will happen correctly. Somebody wanted to ask a question. Just put it in the chat box or message me, because I can't see you, so I can't. Yeah, searching through the crowd will be very difficult. So please just message me your question, and either on WhatsApp or in the chat box, and I will attend to it. Okay. Then in the long case again, history taking. So that format is given in your log books. You just have to revise that, keep a blank paper with you so that you can practice it in the coming days. Ah, so somebody wants to know what are the suturing technique. So basically, if you know interrupted suture well with an instrument, it is fine. Okay, so I'll send you the marking scheme also. That should be also fine, so that you know how to tie the suture correctly with an instrument, that we've done it oftentimes. So the other types of sutures, maybe if there is a viva question, maybe it will come up. But otherwise, when you have to demonstrate your skill, it will be just three or four interrupted sutures, how you can tie it with an instrument, and that you are able to discard it in a proper, adequate, and bio waste manner. So, and if the suture is to be removed, we normally pull up the suture and cut the suture close to the skin, so that the least amount of thread which is lying outside goes through back into the wound. So, those are the few principles. Hello, hello, hello. Yes, so confusion is here only. For appendicitis, we use Mantrel score. For pancreatitis, we use the Ranson score. So if you know the values as well, please do that. Just the criteria is how we start off in year three when I teach. So we start off by learning the criteria. By year five, normally the values come and stick to our mind. So just five, like how we've eventually picked up the what is the normal pH, 7.35 to 7.45. So similarly, that PaCO2 uses the last two digits of the pH. So the PaCO2 is between 35 to 45 millimeters mercury. So like that, we will find some associations. So similarly, we have for Ranson score for GA law, glucose we know 200 milligram per deciliter. Then age we know more than 55. And then AST and LDH. So LDH we know is more than 350, AST more than 250, and WBC count more than 15,000. So eventually you will learn it, but don't be hesitant to make an effort. Okay, so that is very important. So always make an effort. So first just write down GA law and CHOBBS, so that you know what is the criteria on admission and what is the criteria which are assessed in acute pancreatitis within 48 hours. So once you've got the criteria, eventually through experience and talking to your friends about it, the figures will come to your mind slowly. Okay, so don't think it's too much of a task. Eh? Same question. Okay, I hope that answers it. Otherwise, you can ask it again if it is not clear. Then, for the long case, history taking is important. So, all those aspects in history, please remember that this will again be different from how you are seeing the Houseman report. So, many specialists, of course, want it reported like how a houseman report, where everybody knows the diagnosis in advance. But please, for MBBS examination stage, it is taken that you don't know the diagnosis. Nobody knows the diagnosis. Patient has come for the first time and is being evaluated. So start off from the beginning. What was the first complaint which the patient had in relation to the illness? So that becomes the presenting complaint. So that may have a duration of 1 week, 2 week, 3 months, 6 months, whatever it be. That will then give you the chronology of events of how the disease has progressed. Otherwise, if you start off with patient has come for elective cholecystectomy, then there is no history and though no examination and nothing else to go forward with. Okay. So always start off with how the disease started and how it has reached this present stage. In between, if patient gets hospitalized, we only mention the investigations which are done. You don't have to report the results of the investigation unless you are specifically asked. Otherwise, just say ultrasound was done, CT scan was done, patient was advised this, and with that, the patient improved or did not improve. And then you carry on from there. If any operation was done in between, patient was operated 1 month ago, pain is still not relieved, or patient is comfortable now but has now come up with fresh complaints. So, but if it is the same disease process, the history will be the same continuum. So, if you do it like that, it comes out much better and is more understandable by everybody. Something I'm missing. You have been given one score in your Bailey and Love. You stick to that. That is the non-gallstone pancreatitis. So you follow that. So that is easier and will not create confusion. But if you go and pick up both, then for gallstone pancreatitis, the Ranson score levels are much higher. So it will get very confusing. So just stick to one. Otherwise, for severity grading, if you are really getting pressed and getting confused with all this, stick to the Atlanta, which mild, moderate, and severe. Mild when there are no systemic complications, moderate when there is transient organ failure, which resolves within 48 hours, and severe acute pancreatitis, where the organ failure does not resolve within 48 hours. The only hassle here is that on admission, we don't know whether organ failure is going to resolve or not resolve. So we assume most of the cases on admission are mild and there is no organ failure. If there is organ failure, we have to wait and see whether that organ failure is going to respond to our treatment in 48 hours. So we will know that answer only later. And that is why we use the Ranson's criteria on admission to give us some idea. So workable one is what is given in Bailey. Please use that, and that should remove the confusion. I hope that is clear. Name of criteria. If you just stick to Atlanta criteria, you'll be fine. The Atlanta meetings have happened a number of times. So the definitions have got revised. And that is the revised Atlanta meetings have revised the definitions and the criteria by which we diagnosed acute pancreatitis and things like that. So don't, if, as long as you stick to Atlanta, you're going to be fine. Okay. Don't split too many hairs. Life is not that difficult. It's going to be easy. Okay. So as long as you are able to bring out the Atlanta criteria, you're going to be fine. Should we do a general examination? Ah. Now, see this difference between general and local. Now, please remember that it depends on what case you have. Whether if it's given as a long case, then you will follow everything as you do. Then you will do everything like a standard long case evaluation, that is starting from general examination, coming down to the concerned systemic examination, and then the general systemic examination of other system. Okay. So that is when you have it as a long case. When you have it as a short case, then usually the examiner will specify the history and say this patient has presented with so and so. Please do a examination of the breast. Please do an examination of the abdomen. Please do an examination of the groin. So that the examiner will specify to you or will be even written on your slip. Huh? One of the ah So, radiological findings to support a diagnosis of acute pancreatitis. So, among the radiological findings, most of the authors they go for CT or MRI. Nobody is mentioning ultrasound. But please remember, ultrasound is the first investigation which is done. But the aim is not to diagnose the acute pancreatitis. Most of the time, acute pancreatitis would have been diagnosed based on pain and elevation of serum amylase or lipase. There are very, very few situations where the serum amylase and pain do not meet the criteria in a case of acute pancreatitis. They are very, very rare cases. Patients who are coming late, serum amylase has already started dropping. So that scenario normally doesn't happen. So though theoretically it's possible, most of the time they get diagnosed based on pain and the elevated serum amylase. Ultrasound is done to look for gallstones, and if there is the cause is choledocholithiasis, either recent passage of the stone or a stone is still stuck there and causing continued irritation to the pancreas. If that is so, then in that ultrasound is done to detect that stone and do an ERCP within 72 hours. So that is the role of the imaging. When we talk of imaging criteria, so in all these anatomical imaging methods, whether we use ultrasound or whether we use CT, MRI, in all of them the criteria for inflammation of the pancreas is the same. First is edema of the pancreas, next is peripancreatic fat fluid collection, and peripancreatic fat stranding. So these three things, if you remember, so they will be seen on ultrasound, they will be seen on CT, they will be seen on MRI. And in case the it's very severe pancreatitis, necrotic pancreatitis, necrosis of the pancreas may also be picked up. But most of the time, on admission, we'll be picking up edema of the pancreas or edema of the pancreas or peripancreatic fluid collection or peripancreatic fat stranding. Uh, ERCP or MRCP, what is for what? I've not figured this question. Again, see, single word questions, we don't know. Yes, whoever asked this ERCP or MRCP question, please ask in detail what you want. Either verbalize it. For year 4 CA, are we focused with Y4 topics? Um, the extra focus is on the new topics which you've learned, but you cannot ignore knowledge which you have gained earlier. So this is a progressive continuum examination. So please don't say that we didn't what we have studied in year 3 we have forgotten. Then you will not qualify to reach year 5 because in year 5 we need all 3 years. So year 3, year 4, year 5 all are together. So year 4 is just a gateway. So please revise all topics. Though of course extra focus will be there on the new topics, pediatrics and all that which you have picked up in year 4. Yes, ERCP, MRCP, what was the question? I have not got. Anyway, so we will proceed. By the time you figure out that question, you can get back to me. So talking about intestinal obstruction, we talk of dynamic and adynamic obstruction. Dynamic when there is vigorous peristalsis, which is usually due to either something within the lumen, in the wall or outside the wall. In adynamic, there is paralysis and there is lack of peristaltic activity. Then further we can qualify it based on where this obstruction is occurring, whether it's in the small, large bowel or both. Then whether it is acute, subacute, acute on chronic, chronic, whether it's partial or complete, whether it's no passage of gas and intestinal contents, or there is passage of gas and no passage of intestinal content. Then simple and closed loop. In closed loop, there is obstruction at two places on the same loop of intestine. Like you see in a volvulus or you see in a hernia, that hernia loop has gone out and it is closed off at the neck. So both the proximal loop as well as the exiting loop both are blocked. Then the difference between incarcerated and strangulated. Now, incarcerated is very commonly used, that's why I keep bringing it up so that you know the difference. Incarcerated means it is more to do with hernias which are irreducible or something which is imprisoned and not moving. But a strangulation implies that blood supply is cut off. So incarcerated cannot mean strangulated. So that be very careful. Many people or many authors, many articles mentioned incarcerated and also include a term about to be strangulated. So nobody is an astrologer who can tell that this is going about to be. So either the blood supply is compromised or not compromised. About to be compromised is a prediction which no doctor can actually make. He can pretend to make, but he cannot actually make. So remember this differentiation, that incarcerated means irreducible or trapped in some place. It has got no significance regarding the blood supply. And strangulated means that the blood supply is compromised. So closed loop obstruction, we commonly see this coffee bean sign, which we see in a sigmoid volvulus. And it can also occur in carcinoma colon if the ileocecal valve is patent, so that it is not permitting, it is only permitting one way flow and it is not permitting return. So there is obstruction here in the sigmoid colon, and the gas and intestinal contents cannot proceed beyond the sigmoid colon, and neither can the contents go back. So this is a closed loop obstruction. Now what will happen? The closed loop keeps distending and that eventually compromises the blood supply. Then we talk of small bowel obstruction. So in small bowel obstruction, we see that the distension is in the center of the abdomen, and here the all intestinal obstruction will have pain, but here the vomiting will happen early, because small intestine close to the stomach, all these distended contents will go back through the duodenum into the stomach and patient will vomit. Now these loops of intestine, they will be more than 3 centimeters wide. Now looking at it, we can't sort of make a guess, but we can make an approximation that yes, the loops are looking wider than the vertebra, so maybe they are more than 3 centimeters. But actually we always require a radiologist to measure. So in some of the x-rays you will see that there is an arrow mark running across the width of the intestine and the distance has been measured by the computer. So we need, so that is the 369 rule, that the intestines, if they are more than 3 centimeter in the small intestine, or the large intestine more than 6 cm, or the cecum more than 9 cm, then it points to intestinal obstruction. Then if we see more than 3, here we are seeing 7 8 fluid air fluid levels, and which are wider than 3 cm, that also points to an small intestinal obstruction. Plus we are not seeing gas in the colon. So that is very, very important, that wherever there is obstruction, beyond it there will not be gas. A little while back somebody asked me about duodenal obstruction and jejunal obstruction. Now in this case, the duodenum is also not going to be dilated, but it cannot be duodenal obstruction because the jejunum is showing gas. So once there is gas beyond it, that area cannot be. Okay. So, similarly, when you come to cecal obstruction, you cannot have gas in the rest of the colon. If the cecum is obstructed with the cecal volvulus, the ascending colon, transverse colon, descending colon, sigmoid colon will not have gas. So, wherever there is obstruction, beyond it, there is no gas. So, here the gas is in the small intestine only, so it is small intestine obstruction. Beyond it, we are not seeing gas. Like here we are seeing distended loop hostrations. So this is you are seeing in the periphery of the abdomen, distended loop. So that is large gut obstruction. And these are hostrations which don't run through the full length of the bowel. This distant thickened mucosa only halfway, does not run through full. If it was running across fully, it would be a valvulae conniventis. So these are distended loops of colon, and gas is reached till the sigmoid colon. So the block is at the sigmoid colon. Then this bowel perforation, this also sometimes crops up as a OSCE question regarding what are the features of intestinal perforation which we see. So we are seeing gas under the diaphragm. How to make out the diaphragm? We look at the heart and we see this linear density going from under the heart to the side of the chest. So that is only thing possible is a diaphragm. Now, normally under the diaphragm lies the liver, so that you don't see the diaphragm separately. The liver is just underneath it. But here, because of the air, the liver has got pushed down. So then we call this condition as pneumoperitoneum or gas under the dome of the diaphragm. Next sign we are seeing here is Rigler sign, that there is gas inside the lumen of the intestine and gas outside, so the wall of the intestine is clearly made out. So, so we got again. The question has to be asked very clearly. Current management of which condition? Anyway, to put the confusion at rest, if we are trying to distinguish between ERCP and MRCP. Now, please note that ERCP is an invasive investigation and it has got the potential for therapeutics also. So, only if we are looking at a therapeutic solution, we will do ERCP, but most of the time we will prefer MRCP because it is not invasive. Now, please don't confuse it with what you see recommended in certain situations and all that. We must have a clear idea of what is best for our patient. But there may be certain circumstances that you cannot transfer, or the MRCP machine is not working, or there is no slot. So, all those kind of situations are there. But remember, ERCP is invasive and it alone can cause complications. And we must know what are the complications of ERCP. MRCP is non-invasive. So there is no invasion happening. So all those complications of ERCP not there in MRCP. Plus in ERCP we are injecting dye. Here we are not injecting dye. No cut is being made. So ERCP by itself, when we are trying to manage stones, we can cause pancreatitis. MRCP again, no danger of causing pancreatitis. So all those advantages are there by this non-invasive method, and the uh, quality of image which we get is equivalent in both. So the same amount of the here in MRCP, the bile acts as the contrast, because in T2 weighted images, the bile shines out as if the patient has been given contrast into the biliary system. Whereas in ERCP, we have to inject a contrast to opacify the biliary channel. So I hope that is clear. But whenever we are trying to remove a stone, or we already know through ultrasound or MRCP that there is an obstruction which requires stenting, then in those situations for therapeutic purposes, then we would like to do an ERCP. The next question was pediatric surgical. Yeah, so for pediatric surgical, it's only these standard common conditions which we are seen, or if you have seen an operation that maybe you would know more about. But by and large, we are looking at either it is to do with the hypertrophic pyloric stenosis, Hirschsprung's disease. So those are the common conditions which we encounter, and you must know what we do in that situation. Rest of the details in pediatric surgery for gastroschisis, Umfellos are all long-term conservative management followed by repair of the hernia, which necessarily follows because of that large defect. And a standard inguinal hernia, umbilical hernia management. So it's nothing very complicated in pediatric surgery. Okay, so don't have to master the entire pediatric surgery book. Okay. Yeah, so we covered gas under the diaphragm. We've got the Wriggler's sign, and then there is something called the triangle sign. Because this gas is present even outside the intestine, so the small areas between the intestine and the wall, or between two loops of the intestine, these small black triangles become visible, and that is the triangle sign, which also points to bowel perforation. Here also you are seeing regular sign, you are seeing the valvulae conniventis as well as the wall of the intestine clearly demarcated. Plus additionally we are even able to see the falciform ligament, but don't worry too much about it. As long as you know gas under the diaphragm, you know regular sign, you know triangle sign, you are okay for intestinal perforation. Then coming to this adhesive small bowel obstruction or adhesive intestinal colic. So there are many cases which get diagnosed like that. But please remember, intestinal colic is a symptom. It has to be a bowel obstruction. So adhesive small bowel obstruction will be the diagnosis. It can be incomplete, it can be complete, but the diagnosis is a bowel obstruction due to adhesion. Now, whenever we are trying to manage a patient with bowel obstruction, so the first thing is when we do the history, physical examination, laboratory values, we are trying to rule out whether there is perforation, peritonitis or not. So if there is any evidence that there is peritonitis, strangulation as upper bowel vascularity is compromised, then patient goes directly for surgical operation. So clear cut one channel when we do the initial assessment and resuscitation and investigation. During the investigation, if it emerges that the patient has got peritonitis or strangulation, then we will immediately go for surgery. Now, in case that is not there, patient has just got intestinal colic, which gets relieved, the bowel abdomen is quiet, then we can evaluate this patient further to find out what is causing the obstruction. Is it some growth inside the lumen? Is it a stricture in the wall? Or is it a band which is causing compression? So for all that, a CT scan is able to show us the structures very clearly. And we continue conservative treatment for that patient, and whether the CT scan which we have done, if that contrast passes through the entire intestine in 24 to 36 hours, that means there is no intestinal obstruction and patient is cleared to be started on oral feeds. But in case during this period patient deteriorates, or you have found some evidence that bowel is going to perforate, then patient goes for surgery. And in case the uh, oral contrast does not reach the colon in 24 hours, or even till 72 hours if we have waited, then we can think of it as a failure of our conservative treatment, and we proceed for surgery. So just two channels: one, if there is suspicion of peritonitis or vascular compromise, immediate surgery. If that is not there, a trial of conservative treatment and a CT scan to look for the obstruction. And if during this period, if patient improves, the dye passes, or patient is able to pass motion, then no problem, conservative conservative treatment is successful. But if 72 hours pass, no improvement, or patient's condition is deteriorating, then again patient goes for surgery. Then coming to all these urological conditions. Now, carcinoma, kidney, renal cell carcinoma, these lumps are also quite common, and patients with usually present with hematuria. So, pain, mass, hematuria, weight loss, these are the standard features with which patients with renal cell carcinomas present. Now, renal cell carcinomas can be cured if they are treated promptly, and the operation which is recommended is either a partial nephrectomy or a radical nephrectomy. So partial nephrectomy, radical nephrectomy, and in case the disease has gone into the vein, renal vein, in case there is progression into the renal vein, it becomes a T3 tumor. In that situation, two surgery can be done successfully. So don't sort of condemn the patient to palliative treatment just because the carcinoma has been shown to go into the renal vein or even the inferior vena cava. Then coming to carcinoma bladder, so all these renal tumors, exposure to one, tobacco smoke, and second to paint and dyes. So these are the usual etiological factors. And these tumors can be low grade, high grade, but more importantly, whether it is muscle invasive or non-muscle invasive. So standard we know in the TNM staging, T2 disease is when the cancer has invaded the muscle. So either the detrusor muscle or muscularis propria, one of these two terms will be given. That means the disease has gone into the muscle. And in case it has gone into the muscle, then the treatment is radical cystectomy. But if it is a non-muscle invasive disease, that is it in the mucosa, submucosa, then you can do a transurethral resection of bladder tumor and intravesical chemotherapy, mitomycin C or BCG, that can be instilled. So that is the immediate treatment for non-muscle invasive disease. So just remember these two. Again, see, no confusion. Surgery is actually a simple specialty, but we need to be very careful about the anatomy and how we proceed systematically. If you proceed systematically, there is no difficulty. So non-muscle invasive disease, so these images you don't have to assess. So when these images are given in the question, their interpretation will also be given. That this is showing a papillary tumor in the bladder, which is non-muscle invasive, and treatment may be asked. Or this is showing a papillary tumor in the bladder, which has invaded the muscle, and your treatment may be asked. So just remember, for superficial non-muscle invasive disease, the treatment is TURBT and installation of chemotherapy like mitomycin, intravesical chemotherapy. And for muscle invasive disease, the treatment is radical cystoprostatectomy or cystectomy, and with an ileal conduit drainage. Then coming to carcinoma prostate, this is usually seen in the elderly individuals more than 60, 67 years. And here, what will become important is that with what comorbidities, because by that time some cardiac, some neurological, some comorbidity patients are carrying. And the symptoms will be similar to benign prostatic hypertrophy. So frequency, urgency, weak stroom. So all that we learn in the SPSS scoring system, that will become useful here. The fun wise mnemonic we have for this: frequency, urgency, nocturia, then weak stream, intermittency, straining, incomplete emptying. So all these are the fun wise symptoms are applicable, and carcinoma prostate may have all those symptoms. So when we need diagnosis, malignancy is only diagnosed on histopathology. So transrectal ultrasound guided core needle biopsy. So that will give us the TNM stage, and then we assess the patient's health situation. So apart from the TNM staging of the prostate cancer, we will assess the health of the patient. So different from all other situations. In prostate, we have a special category of T1 where no disease is detectable on digital rectal examination or transrectal ultrasound, but the biopsy is positive. So, biopsy may be positive because PSA is elevated and you do a transrectal ultrasound guided core biopsies, or we do a TU RP, that is for a benign prostatic enlargement, and when the chips are sent for histopathology, that comes back as carcinoma prostate. So that is T1 when there is no disease detected clinically but histopathology is positive. When disease is confined to the prostate, it is T2. When it goes outside the prostate, T3. And when it involves adjacent organs like the prostate involving the bladder or prostate involving the rectum or the pubic bone, in that situation it becomes T4. So in all these situations, we assess whether the patient is low risk or high risk. So low risk standard, don't you don't have to remember all these categories, but just remember in low risk patient, the PSA is low. PSA is low, disease is localized. In high risk patients, the PSA is high and the disease may be T3 or T4. It has gone outside the prostate or involved adjacent structures. So PSA is high, disease has gone outside the prostate, considered locally advanced. PSA is low and disease is confined within the prostate, it is localized disease. So basically these two separations we keep in mind to which prostate cancers are low risk and high risk. Then we assess, this is not for you to remember here, maybe in community medicine or somewhere you would require it, or in family medicine, but it is for that purpose only, that we try and assess whether the person is fit or whether he is terminally ill, because if he's got advanced comorbidity, then he does not qualify for radical treatment, so which comes up here. Then if patient's life expectancy is low, then we will only watch and wait to see any complications of that carcinoma prostate happening. If there is low risk disease, that means PSA is low, it is T1 and T2, then we can again watch that this disease is going to progress slowly. But if it is a high risk disease, that PSA is high, disease is already T3, T4, then we will offer aggressive treatment, surgery, external beam radiotherapy, or androgen deprivation therapy. In metastatic disease, it's androgen deprivation therapy. So all these types of treatments are there. Main thing is to how to stop the testosterone secretion. Then in case it becomes castrate resistant, so castration resistant prostate cancer, some newer drugs are available. So if you like to remember, well and good, otherwise know that there is therapy available including chemotherapy for patients who stop responding to androgen deprivation therapy. And now we have this new kid on the block, the PSMA PET scan. So the prostate specific membrane antigen, we can do a positron emission tomography. So PSMA PET scan. So earlier we were doing only bone scans and they were able to pick up metastatic disease in the bone. So in the soft tissues of the lymph nodes recurrences we were unable to pick up. Now, with the PSMA PET scan, it picks up prostate cancer cells wherever it may be, whether it's in the bones or whether it's in the lymph nodes, it can be picked up. And then the next advantage, like we have in ERCP, is that apart from diagnosis, we can this radioactive substance lutetium we can attach to the PSMA and inject it back into the patient, and this high dose radiation will travel all over the body, and wherever there are prostate metastatic deposits, it will work on that to kill the malignancy. Now coming to peptic ulcer perforation. Now in peptic ulcer perforation, the standard, this an OSCE keeps cropping up, gas under the diaphragm, which now you are quite able to determine under the heart, linear shadow going to the side of the chest, and in case liver was attached, this would not be separate, But now the liver is down, and in between this line and the liver, you can see some air. So this is pneumoperitoneum. Same story here. So this is an abdomen erect view, this is a chest erect view. And how will we treat? Again, for all emergencies, treatment is same. Telling you, surgery is simple. Assess and resuscitate, ABCD protocol, put the patient nil by mouth, put a nasogastric tube, IV fluids, antibiotics, analgesics. Then do the routine investigations to assess the general condition in case he's got kidney failure, liver failure, respiratory failure. So all that will get sorted out. Then if when he's fit or he's resuscitated adequately, we do an exploratory laparotomy, peritoneal washout, close the perforation. We can put a Graham's patch or a Thal's patch. And in case it is peptic ulcer disease, and we are able to confirm that it is H. pylori, then we will do eradication treatment. Otherwise, in perforated peptic ulcer, patient has a long course of antibiotic treatment that alone may eradicate the H. pylori infection. Then the next complication is hemorrhage. So in hemorrhage, we have the Forest classification 1, 2, 3. There is no 4. So sometimes in MCQs, we also include 4. There is no 4. So only 1, 2, 3. And in 1, there is active bleeding, which may be spurting or oozing. So in 2, we have evidence of recent hemorrhage. So which may be a visible vessel, clot which is adherent to the ulcer, or a pigmented spot. So these three things are included in 2. In 3, it is a clean based ulcer. So this ulcer is healing, it has got a clean base, it does not have any pigmented spots to indicate where the blood vessel has bled from. So that is 3. So Forest 1, 2, and 3. Then you come to carcinoma stomach. In carcinoma stomach, again, etiology is H. pylori, advanced stage, pale sex, diet low in fruits and vegetables, diet high in salted, smoked, preserved foods. Pathology, we have two types, intestinal and diffuse. In addition, there is the Japanese classification for those who would like to remember. But if you remember intestinal and diffused, adequate for MBBS level. Japanese classification, additional, protruded, elevated, flat, depressed, and ulcerated for early gastric cancer. Then there are several molecular subtypes which indicate the uh, what type of disease, like you have in breast cancer, whether it's going to respond well to treatment or respond poorly to treatment. So the worst ones are these genotypically stable ones, they behave the worst. Then most common site for gastric cancer in the West is proximal stomach cancer, that is at the esophageal gastric junction. But in Japan, rest of the world, Malaysia, most of the places, though here we are trying to say in some states that the Western pattern is common, but on an average in Japan and the rest of the world, it is distal gastric cancer. That is the part near the pylorus which becomes malignant. Then clinical features, in early gastric cancer there will be no features, but in advanced cases, because there is infiltration of the stomach wall, you will get these features of early satiety, bloating, distension, vomiting, anemia, dysphagia, epigastric fullness, weight loss, migratory thrombophlebitis. So please remember Trousseau syndrome. We know Trousseau sign. Trousseau sign in hypocalcemia, but Trousseau syndrome is migratory thrombophlebitis. Unfortunately, Dr. Trousseau himself, who described it 2 years later, developed Trousseau syndrome and eventually died from the advanced carcinoma stomach. Carcinoma stomach, TNM staging, it is standard for all luminal cancers T1, T2, T3, T4. T1 when it goes into the submucosa, T2 when it goes into the muscularis, T3 when it comes into the subserosa, and T4 when it involves the serosa. So the same pattern will be there for all, whether you're talking of stomach, colon, rectum, urinary bladder, esophagus. So everywhere the pattern for all luminal cancers is the same. And here the treatment, either a total gastrectomy or a distal gastrectomy. This, of course, Bilroth 1 we will not be doing. This is mainly for peptic ulcer disease. Usually three-fourths of the stomach will be removed. So most of the time we will be doing a Bilroth 2 anastomosis, or the one which is preferred is this total gastrectomy, that the entire stomach is removed and an esophagojejunostomy is done. Now, this in Viva, possibly in theory, when we had one question earlier regarding the lymphatic drainage, so there is a difference in D1 and D2 lymphadenectomy for gastric cancers. We recommend a D2 lymphadenectomy. So the Japanese group who have got the most experience in carcinoma stomach, they recommend a D2 lymphadenectomy for gastric cancer. So what is the difference between D1 and D2? D1 incorporates the lymph nodes which are in the perigastric region, that is by the side of the esophagus, lesser curvature, greater curvature, suprapyloric, infrapyloric. So these are included in the D1 group. In D2 group are the lymph nodes which are along the named vessels which supply the stomach and the surrounding regions. So here we have the celiac axis, the common hepatic, the splenic, and the other vessels which are branching off from these. So the pancreatoduodenal, gastroduodenal, so all those, but if long as you remember the celiac axis, the common hepatic, left gastric, and the splenic, which are the main branches of the celiac axis, the artery of the foregut, all those will cover the D2 lymphadenectomy. Then complications of peptic ulcer, leak, and we have anesthesia related atelectasis, aspiration, deep venous thrombosis. So this all your patients, whether it's peptic ulcer, thyroid, so whatever major surgery is done, anesthesia related complications will be common. Then in stomach, once the stomach has been removed, there will be nutritional deficiency, recurrent ulceration, small stomach syndrome, bile reflux, the two types of dumping, early dumping, which is due to the osmotic load, and late dumping, which is due to hypoglycemia due to the insulin secreted when the food first enters, and later in 2-3 hours the stomach has not is missing, so no absorption has taken place, and excess insulin has been secreted by the pancreas, so they go into hypoglycemia. So late dumping will respond to a carbohydrate meal, whereas early dumping a meal will aggravate the problem. So here just lying down in bed or drinking plain water is the solution, whereas for late dumping a carbohydrate meal is recommended. Then coming to thyroid. Yes, here also sometime back I heard some discussion on the thyroid gland. Now remember that the thyroid gland, if it is palpable, it is definitely enlarged, because the normal gland is not palpable. So if you are able to feel the gland, it is enlarged, and normally we take the yardstick of the patient's thumb. So if the each lateral lobe has a volume greater than the terminal phalanx of the thumb. So if the patient's thumb is this much, my one lateral lobe is only going to be this much. So this much in the neck is very difficult to feel. So if you are palpating the thyroid gland, then it is definitely enlarged. And the WHO gives these two gradings for enlargement of the thyroid gland. So it may be palpable but not visible, then it is grade 1. And if it is both palpable and visible, that is a grade 2 enlargement. But most of the time for your examination, in clinical examination, you will get a big thyroid. So the trick there is to always first identify that it is a thyroid. Why do you say it is a thyroid? Because it moves with deglutition, does not move with protrusion of the tongue. And then smartly just mention the two lobes. So the right lobe measures so and so, left lobe measures so and so, isthmus measures so and so. So then you are very clear, you don't have to then beat about the bush. First establish that it is a thyroid and then mention the dimensions. So whatever you have measured in palpation, those you bring in your inspection. Don't try and say that your eyes are so good that you are able to approximate and say it is 4.5 or something like that. But you have measured it. So if somebody asks, how are you so accurate? In palpation, I have measured it and it is 4.5 or it is 5 centimeter by 5 centimeter. So whatever is the dimension, be very clear about that. Then we inspect the thyroid from front, then we inspect it from the side, then we palpate, then we percuss. This sequence is wrong. We inspection, palpation, percussion, and then auscultation, and then we look for the signs of toxicity. Then when we are looking at the thyroid gland, if we find that it is a diffuse soft goiter, then it's likely to be Graves' disease. And if it is firm, then it is likely to be Hashimoto's thyroiditis. And if it is tender, then it is going to be subacute thyroiditis. And if you are finding multiple nodules, then it is a multinodular goiter. Now, this between solitary nodule and multinodular, again, we have to be careful. Remember, the definition of a solitary nodule is a single nodule in an otherwise normal gland. So when we palpate, we cannot sort of certify that the other part of the thyroid gland is normal. So it's a clinically apparent solitary nodule of the thyroid, but will have to be confirmed on ultrasound. So the solitary nodule only gets confirmed on ultrasound. Then, so if you are able to feel a nodule and you can feel the other gland also, the other lobe also, then it is a multinodular goiter. Because solitary nodule has to be a solitary nodule in an otherwise normal gland. So the rest of the gland or the opposite lobe has to be the size of the patient's terminal phalanx and not palpable. In case you are able to palpate it, then the classical description is a multinodular goiter. And thyroid hormone synthesis, this I'll not take up your time now. Then in thyrotoxicosis, we can have all the features which we know, we can assess them. Then whenever we get a patient with thyrotoxicosis, then we have to see whether there is Graves' disease, toxic adenoma, toxic multinodular goiter, or there is something else which is producing the TSH, which is causing these features of thyrotoxicosis. So thyrotoxicosis is a state of excessive T3 and T4 in the patient. So this may be associated with hyperthyroidism, that is a increased RAI uptake over the neck, and it may also be associated with a low radioactive iodine uptake in the neck. And that is when the thyroid gland is getting destroyed by thyroiditis. So then the T3, T4 which is in the gland is released, but the gland is actually hypofunctioning. So thyrotoxicosis is just a state of excess T3 and T4. It is not always a state where the thyroid is hyperfunctioning. So when the thyroid is hyperfunctioning, radioactive iodine uptake will be high there. So which is usually seen in Graves' disease, thyroid adenoma, or solitary nodule toxic nodule, or a toxic multinodular goiter. So these are the common conditions. So this is rare that there is a pituitary tumor which is producing TSH. So most of the time our disease will be limited here. Then once we evaluate our patients, so most of the time we will be doing a ultrasound of the neck. So first is TSH, then we do an ultrasound of the neck, because radioiodine uptake is not available everywhere. But if it is available, of course we will do it. But otherwise we are doing serum TSH and we are doing thyroid sonography. But these days with sonography we have the additional feature that we can find out the blood supply also within the gland, so which will give us something, some idea regarding the functioning. So if the gland is enlarged and it is hypervascular, then we know that it is hyperfunctioning, so that it is going to be positive on the RAI uptake also. So that is how we cut sort of corners and are able to still make a diagnosis without having to go through this step of radioiodine uptake. But if possible, then we will do the radioiodine uptake also. Then once we done the sonography, if we suspect that one of those nodules is likely to be malignant, then we will do FNAC. Now, if the FNAC reports benign, no surgery. If it reports malignant, total thyroidectomy. But if it reports an in between situation of a follicular neoplasm, atypia of undetermined significance, suspicious lesion, so in all these, we will need to confirm the diagnosis, and that is the situation where hemithyroidectomy comes in. So benign no surgery, malignant total thyroidectomy, and in a suspicious lesion or a follicular neoplasm, we will do a hemithyroidectomy to confirm the diagnosis. Then, yeah, sorry. So when is surgery considered in nodular thyromegaly? So when the nodules are growing, nodules are more than 4 centimeter, nodules which are causing compressive symptoms, or nodules which raise suspicion for malignancy due to other features which may be there, as well as in the patient desires. So patient desire that yes, cosmetically it is troubling me, please take it off, we will do surgery. So mainly if there is suspicion of malignancy due to any of these features, or if patient desires, we will do surgery for nodular thyromegaly. Now, in differentiated thyroid cancer, we want to get rid of the malignancy and see that it doesn't come back. So, for all those features, the standard treatment, the standard operative approach for differentiated thyroid cancer is a total thyroidectomy or a near total thyroidectomy. All these other situations are given are very, very rare. So most of the time our patients are going to be in this group with a large lesion, and we are going to recommend a total thyroidectomy. So neck dissection is indicated if the neck nodes are involved. So if neck nodes are not seen to be involved, we can leave it. And subsequently, after the total thyroidectomy, we do a radioisotope uptake scan. And in case there is significant uptake in the thyroid bed, we do ablation. And then we give the patient T3 for TSH suppression and follow up. At follow up, we check ultrasound neck, thyroglobulin, diagnostic thyroid scan, and if there is any metastatic disease or a local recurrence picked up, we can do a radioactive iodine ablation again and again go back to this cycle of T3 for TSH suppression and follow up. Now, medullary thyroid cancer does not belong to this group of differentiated thyroid cancer. It starts in the parafollicular cells, which are from the neuroectodermal derived. So, neuroectodermal derived, and they specifically produce the calcitonin. So, we can detect these high levels of calcitonin or CA whenever we have got a case of medullary thyroid cancer. Now, since these tumors are not TSH dependent, do not take up radioiodine, so those second steps of treatment which we had, they are not going to be applicable here. So here what we are going to do is always do a total thyroidectomy and remove all C cells which are likely to be involved, plus do an elective dissection of the central neck compartment, which is level 6. Last category of thyroid cancer is anaplastic thyroid cancer. So these cancers, they develop very rapidly and quickly involve the trachea, esophagus, and it's quite a morbid condition because the patient dies very quickly in 2 to 3 months time. So most of the time there is no scope for any treatment, and they are best managed only with palliative care, even sometimes not doing a tracheostomy even when there is infiltration of the trachea. Now, standard, I said, complications of any surgery, this keeps getting asked. So, we must know hemorrhage and infection, primary, reactionary, secondary, superficial incisional SI, deep incisional SI, organs based. See, you've got so much to write if you write all this in detail instead of just writing one word hemorrhage. Okay, so hemorrhage, which may be primary, it may be reactionary, may be secondary due to wound infection or infection at the organ space, and surgical site infection, it may be superficial, deep. So, like that, there are so many expansions you can do to just these two. Then in thyroidectomy, there is danger to the recurrent laryngeal nerve, danger to the parathyroid glands, and when we do a near total thyroidectomy, patient develops thyroid insufficiency. And in case patient is not prepared adequately, he can go into a thyrotoxic storm. The car can become a keloid, and of course the anesthesia-related complications like atelectasis, aspiration, pneumonia, deep venous thrombosis, venous thromboembolism, urinary retention, and anaphylaxis. Yes, people are tired. Yes. So somebody wants to ask whether it's a dominant nodule. Well, this is just, I think, a colloquial term. Means in conversation we use it. Actually, it has got very little significance because the actual significance of any nodule will come when we are doing the ultrasound. So on ultrasound, all these nodules they are categorized at which have got features. So the one which may be apparent to you or palpable to you most may not have those ultrasound features which are suspicious for malignancy. So the radiologist does the ultrasound and decides which nodes or which nodules are more likely to be harboring malignancy, and then he directs the FNAC accordingly. So it's not necessary that yes, it is nice to talk about this is the dominant nodule and we will focus on it, but actually it is the radiologist who does the ultrasound who identifies the suspicious nodules, does the FNAC of the suspicious nodule, and based on that we plan our treatment. So just keep these two categories in mind, either a solitary thyroid nodule where the rest of the gland is normal, or a multinodular goiter. And in a multinodular goiter, whether it's toxic or non-toxic. If it is non-toxic or toxic, we will do an ultrasound and check the nodules for their particular characteristics. If any are showing any features suspicious of malignancy, then the radiologist will target them for a ultrasound guided FNAC. So that will then become your plan of treatment. So if you want more clarity on this, I suggest you read the American Thyroid Association guidelines on management of nodular thyromegaly, and then you will be very clear. Okay. So, yes, the one which becomes malignant may be the most palpable and all that may happen occasionally, but that does not guide our management principle. Management is driven by firm evidence based on ultrasound characteristics of each of those nodules. So, I hope I'm clear.
Uh,
Okay. I think we are all tired. We'll take a break or yes, no answer from anybody.
We can continue, doctor.
Huh?
Continue, continue. We can
Take a
continue.
5 minute break, I think. Yeah?
Okay, sure, doctor.
Yeah, take a 5 minute break because I'm finding little less response. So let's get some people awake. You can take a short walk and join. We'll quickly finish and